Assalamu alaikum. Today we will discuss an important subject in surgery, which is the peritoneum, omentum, and mesentery. We will start with the peritoneum. The peritoneal cavity, as you know, is the largest cavity in the body, with a large, very extensive surface area equivalent to the surface area of the skin, about 2 meters square. The peritoneum is divided basically into a parietal peritoneum, which covers the parietes, or lined the abdominal wall, anterior, lateral, and posterior abdominal wall. The visceral peritoneum lining the viscera. The peritoneum is composed of a thin or single layer of mesothelial cells resting upon fibroelastic tissue, which is very below which there is an extensive network of lymphatics and vessels. The parietal peritoneum is richly innervated, and the visceral peritoneum is poorly innervated. The parietal peritoneum usually have a somatic innervation, while this visceral peritoneum has autonomic innervation. Inside the peritoneal cavity, there is a little or very small amount of peritoneal fluid, only few milliliters, the function of which to lubricate the intestine during, or the viscera during, peristalsis. The parietal peritoneum, as we said, is richly supplied with nerves, so the pain arising in the parietal peritoneum is usually localized, severe, while visceral pain is poorly localized and it is dull rather than severe, and usually refer to the midline, epigastric, periumbilical, and suprapubic area. So the function of the peritoneum can be summarized: in healthy subject, it aids visceral lubrication and aids fluid and particulate absorption. In disease processes, it is responsible for pain perception, inflammatory and immune responses, and it has a fibrinolytic activity. The peritoneum has the capacity to absorb and exude large amount of fluid. This criteria can be used to perform the peritoneal dialysis in patients with renal failure. In addition, the ability to exude fluid in cases of inflammation or malignancy, ascites, can be formed from exudation of fluid inside the peritoneal cavity. Protonitis is defined as an inflammation of the peritoneum. It may be localized or generalized. In most cases, the peritonitis caused by invasion of the peritoneal cavity by bacteria. So, when we use the term peritonitis without any other qualification, certainly we mean that the peritonitis is bacterial. However, there are many causes of peritonitis other than bacteria. We will mention it in the next slide. Acute bacterial peritonitis is often implied. In this instances, the free fluid spills into the peritoneal cavity and circulates largely directed by the normal peritoneal attachment and gravity. So when there is a spillage of fluid in the epigastric area or the upper abdomen, it will tract along the peritoneal attachment, just like a track or a way by which the peritoneal attachment can take this fluid to other compartment. Example, perforated peptic ulcer. In cases of slow perforation, the fluid will spills in the epigastric area. It will be tracked along the right side of the transverse colon, carried by the right paracorticator, then will settle in the right iliac fossa. Even in patient with non-bacterial peritonitis, as we said, the most common cause is bacterial peritonitis, but in a subset of patients, in those patients, there will be non-bacterial peritonitis. Example, acute pancreatitis, intraperitoneal rupture of a bladder, the urinary peritonitis, or the presence of blood in cases of hemoperitoneum. The peritoneum often become infected later on, after a few hours, by the bacteria which arise from transmural spread of organism. There is no real perforation of the bowel, but the normal flora inside the bowel will move and transgress or translocate through the affected bowel wall to infect this peritoneal fluid, and within a few hours this fluid become infected with bacteria, and bacteria will multiply, causing bacterial peritonitis. Example, most of the duodenal and gastric perforation due to gastric or duodenal ulcers, initially they are sterile, and the initial peritonitis is usually chemical due to presence of bile and acid, but later on, after a few hours, this fluid will become infected by the translocated bacteria from the bowel, and bacterial peritonitis will ensue. Causes of peritoneal inflammation or peritonitis are summarized in the following. The most common cause, as we said, bacterial, and the source of bacteria is gastrointestinal and non-gastrointestinal from translocation. Chemical peritonitis like bile, acid, gastric acid or bile, barium. Allergic peritonitis like starch peritonitis. Traumatic by operative handling. Ischemia by strangulated bowel or vascular occlusion. In addition to the familial peritonitis and Mediterranean fever. How could bacteria reach to the peritoneal cavity? The most common cause is frank gastrointestinal perforation. Perforation of the viscus, perforated viscus, either perforated in ulcer, perforated appendix, perforated diverticulum, and etc. Or the other way that the bacteria can reach to the peritoneum is by, as we said, by transmural translocation of the bacteria. Example, pancreatitis, ischemic bowel, vascular occlusion. Or by exogenous contamination from drains, from open surgery, or direct trauma. Or can reach to the peritoneal cavity from ascending infection from female genital tract. As you know, the female genital tract is open to the exterior from the vagina, uterus, and fallopian tubes, can cause pelvic peritonitis. Or by hematogenous spread from septicemia. Microbiologically, bacteria from the gastrointestinal tract or bacteria from non-gastrointestinal origin. The number of bacteria within the lumen of the gastrointestinal tract is usually normally low in the upper intestine, but it increases in number and count as the distal small bowel is reached. However, in disease processes that cause inflammation or stasis in the upper gastrointestinal tract, this will enhance the bacterial proliferation, so any perforation will cause bacterial peritonitis from the start. The usual bacteria that encountered from the gastrointestinal are usually gram-negative bacilli. The most common of which Escherichia coli, Proteus, Klebsiella, The other causes is other than gram-negative is the anaerobic bacteria. The most common of which is the peptococci, peptostreptococci, and the Bacteroid species, in addition to Clostridia walschi. The effect of these bacteria on the host or on the patient is by release of the endotoxin, I mean the gram-negative bacteria, by releasing endotoxin, which is the lipopolysaccharide part of the cell wall, bacterial cell wall. These endotoxin will be rapidly absorbed by the peritoneum, resulting in septic shock consequences. The other bacteria like Clostridia walschi have no endotoxic effect, but it has a exotoxin and exert its action directly on the tissue. Usually these organisms, I mean the gram-negative bacteria and the anaerobic bacteria are usually resistant to penicillin and streptomycin, but are usually sensitive to metronidazole, clindamycin, mincomycin, and cephalosporin. These act on the gram-negative bacteria or anaerobic bacteria, while the gram-negative bacteria, I mean gram-negative bacilli, are usually sensitive to the cephalosporins, especially the later generation of the cephalosporins. They are sensitive to aminoglycoside, they are sensitive to quinolone derivatives such as ciprofloxacillin. The spectrum of bacteria that cause peritonitis are listed here. The gastrointestinal sources: Escherichia coli, Streptococci, Bacteroids, Clostridium, Klebsiella pneumoniae. Other sources, which are mostly from female genital tract: Chlamydia trachomatis, Neisseria, gonorrhea, hemolytic Streptococci, and the Staphylococci. Streptococcus pneumoniae and Staphylococcus pneumoniae can reach to the peritoneum by hematogenous spread in a subset of peritonitis called primary peritonitis. Mycobacterium, tuberculosis, and other mycobacteria can reach to the peritoneal cavity, causing tuberculous peritonitis. Fungi can also share some cases of peritonitis. As we said in the beginning of our lecture, the peritonitis either localized or generalized. There are factors or special defense mechanism in the peritoneal cavity that favor localization of peritonitis and sometimes favor diffusion of peritonitis. So the peritoneal cavity has a special defense mechanism which aim to localize the inflammatory process rather than make it diffused one, because the mortality and the subsequent sequelae of diffuse peritonitis is much more grave and much more severe, much more fatal than localized peritonitis. So localized peritonitis has much good prognosis than diffuse peritonitis. So our aim, or the body aim, to localize the inflammatory process rather than making it diffused. What are the factors making the peritonitis localized? There are anatomical factors and pathological factors. Anatomical factors: the greater sac of the peritoneal cavity is divided into three compartments. As we know, the peritoneal cavity is divided into greater sac and lesser sac. The lesser sac is behind the stomach, while the greater sac, which is the biggest one, will be subdivided into pelvic, subphrenic spaces and the greater sac proper. Again, the greater sac proper is subdivided into a supracolic compartment and infracolic compartment. Any focus of infection in this compartment will be prevented from become diffused to another by these anatomical factors, by its peritoneal attachment. There is peritoneal attachment that divide this compartment into a separate one. But if one compartment is overwhelmed or overflows, it will certainly flow to the other compartment. So these attachment will limit or favor localizing the inflammatory process, which remain localized in one compartment rather than become diffused to another. Pathological factors that favor localization is the presence of adhesion. Once the peritonitis occurs, the adjacent loops of bowel become inflamed, the serosa of the bowel become inflamed, and it will become adhere to the site of infection. In addition, one of the responses to the peritonitis is the serous inflammatory exudate, which aims to dilute the inflammatory process or the inflammatory fluid or spillage of the gastrointestinal tract for a temporary period, so that the other body defense mechanism can fight this perforation or infection. The other process of localization is retardation or inhibition of peristalsis. Once peristalsis is inhibited, so the localization can be done or can be accomplished. But if the peristalsis is present, I mean the wormy movement of the bowel will aid the diffusion of peritonitis rather than localization. So absence or retardation of peristalsis will aims to localize the inflammatory process. The presence of the greater omentum, as we know, is also called the policeman of the abdomen, because it moves toward the site of infection or peritonitis and adhere to the site of infection or inflammation or perforation, and try to seal this area by making extensive adhesion around this area. So it will wall off the peritoneal fluid or the peritonitis. Diffuse peritonitis, a number of factors that favor diffusion. One of them is the speed of peritoneal contamination. As we said, once if one of the quadrants of these mentioned, the quadrant of the peritoneal cavity, is overwhelmed with the spillage of peritoneal fluid, it will overflow to other one, and diffuse peritonitis will occur. So this marked by the speed of peritoneal contamination. The more speed of peritoneal contamination, the more risk of diffuse peritonitis rather than localized. I mean, the factors that favor localization cannot cope، يعني ما تلحق على peritoneal perforation in order to sealing or walling of this peritoneal fluid or perforation. Stimulation of peristalsis. As we said, inhibition of peristalsis favor localization, but in contrast, stimulation of peristalsis by taking oral fluid or stimulation by taking laxative purgatives will aid or favor diffusion rather than localization. The virulence of the infecting microorganism. The more virulent the organism, the less time for the body defense mechanism to cope with the multiplication of these bacteria. Age. Young children, they have small non-developing omentum, so the omentum cannot reach to the affected site or perforation or the initial pathology. Similarly, elderly patient, they have an atrophied omentum. This omentum cannot simply reach to the site of perforation of peritonitis. So those extreme of age, young children and elderly, are at high risk of generalized peritonitis rather than localized peritonitis. Disruption of localized collection. As we said, once nature or the body defense mechanism walled off the site of inflammation, so there is no way to disrupt this what nature has make. So disruption of pericolic abscess or appendicular abscess will aid generalized peritonitis. Deficient natural immunity. A patient who is immunocompromised Examples: diabetic patient, patient on steroid therapy, patient on chemotherapeutic agent, patient with HIV infection or AIDS syndrome. All those patients are liable for diffuse peritonitis rather than localized one. If patient develop peritonitis with appropriate treatment, localized peritonitis usually resolved. And in about 20% of cases, an abscess will form. Infrequently, localized peritonitis become diffused if the patient, if they have deficient immunity, if they have a smaller age group, one of the factors that favor diffusion. Localized peritonitis can convert it to a diffused one. Conversely, a healthy patient will have a potent defense mechanism of the peritoneum and efficient treatment, antibiotic, null by mouth, all these favor localization. So most of the localized peritonitis will resolve or an abscess will form. Conversely, in a favorable circumstances, diffuse peritonitis can become localized, and most frequently in the pelvis or multiple sites within the abdominal cavity. Clinical features of peritonitis. Localized peritonitis, the initial symptoms and signs of localized peritonitis are those of underlying condition. Example, appendix. Appendix usually started with a visceral inflammation, abdominal pain, non-specific abdominal pain, non-specific gastrointestinal symptoms of nausea, vomiting, anorexia, and the colicky, dull abdominal, poorly localized abdominal pain to the periumbilical area or central abdomen, then followed by localization in the right iliac fossa. The pain become more worse and more localized in the right iliac fossa. Specific features of localized peritonitis of any origin is an increase in the temperature, an increase in the pulse rate. The abdominal signs will show tenderness, rebound tenderness, gardening, and rigidity to that localized site. If inflammation arises in the specific area, like the diaphragm, shoulder tip pain may occur due to the sharing the same innervation, the diaphragm and the cervical plexus, which share C2 dermatomes. Another form of peritonitis is the pelvic peritonitis, arising from either the pelvic appendix or a pelvic inflammatory disease due to inflamed tubes, uterine tubes or fallopian tubes. In salpingitis, the abdominal signs is often minimal or absent sometimes, and most of the signs or tenderness can be elicited by the rectal examination or vaginal examination. In patients with diffuse peritonitis, in earlier stages, the abdominal pain is usually severe and usually made worse by moving, coughing, or walking. Usually the site usually begin at the site of the initial pathology. Example, perforated peptic ulcer. The pain started in the epigastrium and rapidly within few minutes to hours separate oval or the abdomen. So this is one picture of diffuse peritonitis. Usually the patient lies still in his bed. He cannot move in order to minimize the pain feeling. There will be tenderness, and the generalized gardening are also found on palpation of the abdomen when the peritonitis affects the anterior abdominal wall. Any frequent bowel sound due to paretic ileus will be heard, and a few hours later these bowel sound will be absent due to presence of frank paretic ileus. And the paretic ileus is one form of mechanism or the response of the intestine to the peritonitis. Pulse and temperature arise according to the degree of inflammation and infection. In the later stages, if the peritonitis does not localized or untreated surgically or medically, if resolution of localization of the peritonitis does not occur, the abdomen will become rigid, tender, severely tender, rigid, and distended due to paralytic ileus. Bowel sound will be absent. There will be circulatory failure with hypotension, tachycardia, sunken eyes, dehydration, and cold nose and cold extremities due to presence of signs and symptoms of septic shock. The face is drawn and anxious, which is called Hippocratic face. And finally, patient will lapse into unconsciousness, which is sequelae of septic, gram-negative septic shock and its consequences of multi-organ failure and death. This picture is a patient with advanced diffuse peritonitis. Clinical features of peritonitis in general, whether localized or generalized: abdominal pain, which usually worse. These are features of peritoneal pain, peritonitis, bacterial or other types of peritonitis. Abdominal pain, which is usually worse on movement, coughing or deep respiration. So the patient try to keep his breathing to his chest, try to make the thoracic respiration rather than abdominal respiration, so that we call it a silent abdomen. On examination, on inspecting the abdomen does not move with respiration, called silent abdomen. There will be constitutional upset of anorexia, malaise, fever, lassitude. GIT upset with nausea, anorexia, vomiting, constipation. There will be fever, raised pulse rate, tachycardia, tenderness, gardening, and rigidity to the site of inflammation, or a diffused one if the peritonitis is diffused, with positive rebound tenderness. Pain and tenderness on rectal or vaginal examination in cases of pelvic peritonitis, absent or reduced bowel sound, and signs and symptoms of shock, which is the inflammatory response syndrome to gram-negative septicemia with the subsequent multi-organ dysfunction syndrome, and later stages. And in the later stage, there will be a risk of death. Thank you very much.